Welcome to the Young Dementia Network webinar. I'm Tessa Guttridge, I'm chair of the network. Today we're continuing our series addressing different issues particular to the diagnosis experience of people with young onset dementia. The webinar, designed and presented today by Alzheimer's Research UK, explores how the preferences of people living with dementia, changes in the political landscapes, and research and drug treatments can help the diagnosis pathway evolve. Very warm welcome to our lovely panelists here. Let me introduce them. Dr. Susan Mitchell, Head of Policy, Alzheimer's Research UK, is leading the presentation and the panel. Shirley Kramer, CBE, Chair of Rare Dementia Support Advisory Board, University College London. Welcome. Professor Nick Fox, Director of the Dementia Research Centre, University College London, and Consultant Neurologist at the National Hospital for Neurology and Neurosurgery. Welcome, Nick. And Dr. Mani Krishnan, Chair of the Faculty of Old Age Psychiatry, Royal College of Psychiatrists, and Consultant in Old Age Psychiatry, Clinical Director for Tees, Esk and Wear Valleys NHS Foundation Trust. Welcome to you, Mani. Catherine Kiley is in the background, Young Dementia Network Coordinator, and she's offering support for us today. So Susan will offer us a presentation followed by a panel discussion, and there'll be time for questions and answers, but please do put your questions into the Q&A function as they occur to you through the webinar. Pop them in there rather than in the chat, please. We've got lots and lots of registrants for this webinar, and those of you who are attending today are not on camera or mic, so please do use the chat freely, and we'll make sure that we post useful links in there as well. So first, and keeping very much in mind that the Young Dementia Network is a community of people living with young onset dementia, family members and professionals working in the field, we wanted to start with a personal perspective from Zac Sherwani, son of Imran Sherwani, a gold medal winning hockey player for Great Britain at the 1988 Olympic Games. He is living with young onset Alzheimer's disease. Catherine, can you run the film for us?
I'm Zac, I'm Imran Sherwani's son. Dad was a sort of very keen sportsman when he was younger. Some fantastic achievements. One of those kind of annoying guys that's good at every sport going. Dad went through the diagnosis process, so I mean, the first challenge was getting him to see a doctor. I mean, my dad's a very proud man, I think, as are many men in general, don't really want to see doctors too much, especially when it comes to kind of mental illnesses or things that you don't like. My arm's broken, I've got to see a doctor, or I feel a bit down, I'm not going to see a doctor about that, and that was very much Dad's approach. So it took a lot of persuading, and I think that was a real strain on the family in order to say, look, there is something wrong here, Dad, you're going to have to speak to someone. So that first kind of getting him to a doctor was difficult in itself before the diagnosis happened. If we look at the diagnosis itself, it went on for about 3 years, and it was a real struggle. I think obviously it was difficult for my dad because he knew there was something not wrong and he was down and he was struggling with things. But for the family, for myself, for Mum, it was really challenging because he was not himself, and we were having to deal with him acting different ways and be a different sort of personality. But at the same time, when we see people and we meet people, they think he was okay. So we kind of didn't know, well, are we imagining this or is this actually happening? And that was really challenging. And the fact the diagnosis took 3 years to happen made that whole stress and that whole feeling of like what's going on obviously also drag for a long, long time. And that was a real challenge. When my dad was finally diagnosed with Alzheimer's, it was, I wouldn't say it was a shock. I think we felt like there was something going on, and we thought it would be, at that point, after going through the diagnosis for that long, that it was going to be something along those lines. So it was almost a relief that we know that there's something going on now. That was very quickly followed by the shock of, right, what does this mean? I don't really know that much about Alzheimer's. What is going to happen? Like, how long does he have to live? How long do we have him as he is now? How long is he going to remember things for? So it was initial relief, but then also followed by a quick kind of, wow, what does this mean? Since the diagnosis, and now we've had time to kind of come to terms with that, and he's started to live with Alzheimer's, he's in a much better place than he was then. So I think the diagnosis did help with that. My hopes for dementia research are to, the first thing is to try and speed up the diagnosis of the disease. I think we suffered a 3-year-long diagnosis, which was really painful, and for us that was one of the most challenging parts of living with dementia. So if we could shorten the amount of time it takes to diagnose someone, allowing them to accept the disease and learn to live with it, that will be a huge help. So first it's to kind of speed up the diagnosis. Another really important thing to think about around Alzheimer's is that it doesn't just impact the older person. I think when I first knew about Alzheimer's, I'd think of older people, grandparents, kind of people in homes that are sitting there and don't sort of know where they are. It's kind of that older generation, but it's not. It impacts people of all ages. My dad's was only sort of early 50s when he was diagnosed with the disease, and it's something that people aren't aware of and need to be more aware of.
Well, pass our thanks back to Zac and Imran, but that has really started us off with a personal perspective, hasn't it? It really grounds us in the reality of the impact of delayed diagnosis, and I hope inspires us to look for improvements. Over to you, Susan, now.
Thanks, Tessa, and really great. Welcome to everyone who's joined us today. Delighted you can be with us for hopefully what will be a really interesting conversation with some great panellists. I'm going to just open up with a poll to start off with, because much of our conversation is about perceptions. We all bring our own perceptions about the strengths, the challenges, the opportunities around diagnosis. So I thought it'd be really useful just to start with a poll. So hopefully Catherine's going to put the poll going live. So the question I'd like you to answer is, do you agree that the majority of the public would want to know if they had Alzheimer's disease prior to the onset of symptoms? E.g., if we could tell people they were developing particularly Alzheimer's disease, just in this case, early, do you think they would want to know? So give an agree or disagree. All thoughts on views welcome. So if you could vote now, that would be great. Wait to give people a chance to vote. Okay, I'm going to ask Catherine to close the poll quite shortly, so if you haven't voted yet, please do. Okay, thanks very much. We've got our results back. And what we find is that 57% of people felt that most of the public would want to know. But interestingly, 43% of people felt they wouldn't. And I think, again, that's really helpful. So if you could just hold those numbers in your heads, and we will come on to this shortly as kind of a bit of a provocation. So I'm now going to just go into the presentation I've got. So I'm just going to share my screen. So just give me a second while I set that up. Put it onto slide view. Okay, lovely. So I'm going to talk to you about some of the perceptions work that we've done around diagnosis. I should stress that this has been looking at diagnosis generally across dementia rather than specifically young onset, but clearly many of the challenges and perceptions apply equally, if perhaps not more so, to the circumstances for people developing young onset dementia. So why is diagnosis important? I know the people in this room care about this, so I appreciate I'm sort of preaching to the converted here, but we know that the scale of dementia is huge, with almost 1 million people living with dementia in the UK at the moment. We know that without changes to disease progression and risk factors, we estimate there could be 152 million people living with dementia by 2050 globally. This is huge, this is significant, and we all know the impact and heartbreak that dementia has both on the individual and those people who are caring for people with dementia. So Alzheimer's Research UK really believe that diagnosis should take place earlier and be more accurate. And it really is the key to accessing the care and support that people will need, which was so, beautifully outlined in the film we've just seen. It's the opportunity to access treatments as they develop. And, this is a really exciting time for new treatments and the hope that they may offer. Is also crucial in terms of giving people the chance to participate in research. The opportunities, and I know, Nick Fox is one of the leading researchers in the country, and he's a great bastion for the importance of research, but giving people the chance to participate in research is so helpful and so positive, I think, for people, and that is crucial. And without diagnosis, people don't have the opportunity to contribute to that. We obviously know diagnosis is challenging. In England, we measure dementia diagnosis rate. Only about 62% of people we think with dementia are even getting a diagnosis, and that's only for the over 65s. We know that the case for the under 65s is much harder and takes much longer. We know that many people don't get told their subtype of dementia. Again, there are good reasons for that, but we do need to challenge what's going on there. And I think from the memory services audit that took place last year, we see there's huge variation between services. Some services have got a very focused, quite specific range of diagnostic approaches, others don't. And some of that just reflects, changing at different access to different diagnostic tests. So this is in no way criticism or a challenge of what's happening in services, but just thinking about where we are and how we can make things better. So I'm just going to talk a little bit about the work we've done around some of the perceptions of diagnosis, whether or not people want to find out perhaps before they've got symptoms, perhaps when they have got symptoms, and also about undertaking diagnostic tests. So first of all, this is some work that we did. We asked both clinicians, particularly psychiatrists, and also members of the public about their views of whether or not they'd want to find out at that pre-symptomatic stage. So on the left, the donut shows that for psychiatrists, there were mixed views. About a third felt that the public would want to know, which was lower than our poll we've just done. A third of psychiatrists didn't think the public would want to know, and a third were neutral. I appreciate we didn't give you the neutral option in the poll, so maybe we'd have got a quite similar recreation if we'd given you that option. And then on the right-hand side, we've got from a different piece of work we did, asking the general public about if they would want to know if they were developing Alzheimer's disease before the symptoms developed. And, a much stronger percentage of 74% felt they would want to know. We could argue the exact numbers. This is not, these are just, polls, and I appreciate that's one quick slice. I think the point here is there is a gap here between the public's desire to know more and perhaps clinical viewpoints about the benefit of it. Next up, about a more formal diagnosis, perhaps when there are symptoms. So at the top, the donut here is asking the public, would you want to seek a formal diagnosis if you were concerned about developing dementia? And we see that 89% would either be very or fairly likely to seek a diagnosis. So there is a desire from the public to know what is going on, to understand what is happening to their loved one. From the work we did with psychiatrists, we see there is a bit more caution about communicating a diagnosis at the early stages. I know that's slightly different, but I think, again, it just articulates there's a gap here between what we can deliver to people and what they would like. Moving on, I think, one of the questions is why there might be some of these differences between clinical and public views. And obviously, there's a whole set of good reasons. I think sometimes there have been people who felt, well, there's no point because there are no treatments. I think what's interesting in this slide, of which this is our Dementia Attitudes Monitor, which asks a slice of the UK population about their views around dementia. Now, 87% of people said they would take a test, would take a test. Within that, 50% of people would take a test whether or not there was a treatment available. So half the people would just want to know. And I think that's quite stark and quite important. There are other people who, I think for understandable reasons, say, well, they'd only take a test if they thought they could be offered an effective treatment or an effective prevention. And about 11% of people said they wouldn't take a test, and then 3% said they didn't know. So again, I think what we're seeing here is the public really want to know more. And I mean, obviously, we need the right information to share it with them, but there is this situation about public desire for more knowledge. I'm just going to move on to a bit more about some of the other perceptions we've got. As I've mentioned, this is an exciting time for new treatments. The lecanemab drug is being reviewed by regulators. It may be available in the near future within the UK. And understanding what the public think about some of this, some of the opportunities and risks, I think is really relevant, and I think helps to build about public perceptions in this space. First of all, just to talk about research. So I I think it's really interesting to note that the work we did with, again, a slice of the public, not influenced by AI UK at all. When we asked them, 69% of UK adults said they would consider being involved in medical research around dementia, mainly driven by the belief that research is the only answer to dementia. That's really significant and really important. I think what's interesting, and again, this is no criticism to services, but in the memory assessment services audit that took place and was published last year, in a review of almost, I think it's about 5,800 case notes, there was only noted in 24% of them that there was any discussion about participating in medical research. So there's a real opportunity there, and I think we should see it as an opportunity. People want to know, and we should hopefully find ways to give them more opportunities to be involved in research. Next up, we're just going to move on to treatments now. Now, we know we don't have disease-modifying treatments in the space yet, but I think it's important to think about what matters. So on the right-hand side, we did some work, again, another survey, we like a survey at Alzheimer's Research UK in conjunction with the University of Edinburgh. And we asked members of the public, some of whom had lived experience of dementia, some of whom might have been at the early stages of developing dementia, and other people who had no relationship at all, about what was mattered most to them if they could have a treatment. What were things would they want to kind of hold on to in their life? And there are 5 kind of key topics, and this was based on analysis of free text using, clever and sensible approaches to this. Reading and writing, driving, interactions with friends and family, supporting or caring others, and meaningful conversations were really important to people in terms of the outcomes that mattered. I think what's interesting to note is that in many of the kind of trials and tests, the kind of outcomes that are used in these trials don't quite align. And I've listed there that the clinical dementia rating scale, which is a key part of many clinical trials, looks at memory, orientation, problem solving, community affairs, homes and hobbies, and personal care. And I think it's just interesting to note there's a gap there about what the public would like to see that matters and what we're able to offer at the moment. I'm sure that will progress and develop. I think it's just worth noting that views were not dependent on whether or not people had a diagnosis or lived experience of dementia. They were fairly consistent across. And I guess the point is that, direct lived experience is so important in terms of finding outcome measures that really matter and make a difference to people's lives, which is ultimately what we're trying to achieve. And then the final point I just want to talk about is obviously new treatments will obviously have had clinical trials, but in terms of what that means for individuals, any treatment obviously can have risks. And I think there's an important point about what's the balance between, benefit and risk for a new treatment. So another piece of work we did with the University of Groningen looked at how willing were members of the public, again, with a range of backgrounds, some with potentially early dementia, people with lived experience, and people with no direct experience, what their views were about that kind of risk tolerance. What we found is that over half of people were actually willing to accept what we kind of define as very high risks. This is what a regulator would describe. So people do have quite a high tolerance to risk in this field. What we find is that, again, lived experience, either as a carer or as perhaps someone living with dementia, did not change your risk tolerance. There was a sense that actually people felt there was the opportunity a drug might offer or a treatment might offer was worth it. I think it's interesting to note there were some slight differences. So if you were younger, if you were male, if you had better education, or if you lived alone, you probably had a bit more tolerance perhaps to some of the moderate side effects. And I think what's also interesting is to compare this to other disease areas, perhaps where there have been new treatments. And what we find is actually, in this space at least, there's greater tolerance for side effects, perhaps reflecting it is in later life, or perhaps just the unmet need that we see in this field. So that's really just the sort of summary of what I've covered. I think there are links here to the different sources I've referred to. So thank you from me. I'm now going to stop sharing my screen and I'm going to open it out to the panelists. I appreciate I've covered a lot of material there, but I would really like it if, or we'll take it in turn for just sort of, 2 to 3 minutes, if each of our panelists could give their views, particularly on perhaps the challenge between perceptions and reality and perhaps what we can do to address that. So I'd like to go to Mani Krishnan first, please.
Thank you, Susan. That's really helpful. I think, again, I would want to thank our colleague who did the video with the father. It was quite passionate and powerful. I think we all know, as a clinician, I deal with it every day, of delay in diagnosis. I think that is something probably we just need to look at how we can move towards early at the same time, accurate diagnosis of Alzheimer's and dementia. So the key things I want to touch upon, thanks Susan for the slides. I think, again, the poll clearly highlighted, if I were to have a condition, I would really like to know whether I have a symptom or not. But the caveat is, what would that do to me is the key here. If I think of, if I were to develop a Parkinson's in 10 years down the line, and then I would have a test that will help me to know I might develop Parkinson's. Again, I might be able to put things in place that will help when I do get it. Compared to that, when it comes to specifically Alzheimer's and dementia, there are some uncertainties. I think that's where probably you could see a bit of an optimism as well as a caution when psychiatrists, again, as a psychiatrist, I think we also deal with people's emotion. So is it about, are we going to heighten somebody's emotion? Because not every single Alzheimer's behave exactly the same way in every single patient. And so it is important that until we know we have a very clear, accurate pathway of diagnosis, it is important. And the other point I want to make on the second thing about, would psychiatrists confident in giving an Alzheimer's diagnosis communication? I think the 60-40 split here, I think that is probably a symptom of probably a bit of a learned helplessness of lack of resources for accurate tools to diagnose. For example, I'm sure Nick might smile. I think some areas in the country, or many areas in the country, we can't even access scans, not the scan report, but we can't look at the scan. The picture archiving system is not available for community psychiatrists. Again, I think the last National Dementia audit said about 43% still haven't got access to the scan. So if you think of, even this morning, I delivered a Alzheimer's diagnosis, only that there was a 4 months delay because the CT scan was reported as generalized atrophic changes. And I had to do another scan, SPECT scan, to look at a specific medial temporal lobe change. But again, the delay was, if that particular CT scan was reported by a neuroradiologist, I probably wouldn't have to even do further scans. It is about that information of psychiatrists and other people who have that ability to, again, it is probably a plea that, again, we've got our patient population, we've got our leaders. It is about, why is it there is an inequality? If it is a cancer diagnosis, we've got a 2-week roll to get some imaging and things done. But if it's a dementia diagnosis, some of the trusts, they don't even have a service level agreement. Again, I'm fortunate to work in a trust where I can send my patient, they can walk into a radiology department and get a scan. But they tried to stop it around COVID, but we've got back that agreement. But there are many areas, even for a scan, which is like 44 pounds, correct me if I'm wrong, it costs only 44 to 75 pounds. And then people can wait up to 6 weeks to 6 months to get a scan. So it is about that access is important. And also somebody put a question on in terms of diagnosis, about who will be able to give a diagnosis. I do want to bring everybody in. I don't think we are here to name only Dr. Krishnan can give a diagnosis. Anybody who have got sufficient, adequate experience and training to assess and give a diagnosis, we should be able to support. And I think without taking further time, I can come back again if needed. So thank you, Susan.
Thanks, Krish. I think my two takeaways from you there were really about the emotional impact of what this means and looking at that as a person. And obviously, as you said, the challenges around kind of infrastructure and kind of staff and skilled capacity. Shirley, could I go to you now as, representing the Rare Dementia Support Group, and perhaps your experiences across the field, and about what your views are about some of the challenges and perhaps some of the opportunities?
Thank you, Susan, and thanks to Tessa and the Young Dementia Network for inviting me. I am a lay person in this area, but I have lots of experience of working in the Alzheimer's field as a trustee of Alzheimer's Research UK and chairing the rare dementia support groups. And a little bit of what I might say is my own personal experience, because since I've been chairing the rare dementia support at UCL, my younger sister, who is 10 years younger than me, has been diagnosed with early onset dementia. So I have a sort of range of sometimes awful experiences, honestly, in this area. So first of all, on the diagnosis, I feel strongly that if we're aiming for early diagnosis, then we have to aim for improved support services, so that if somebody has a diagnosis, there's immediate help and support of how to deal with it, what are the things you need to think about, what are the planning you need to do, what do your carers or your friends need. And I think the patchwork of services that Dr. Krishnan and others have referred to is quite a scandal, and something I know that the charities are trying to do something about, because we need to make sure that we're offering everybody who has this diagnosis. And of course, we'd always say that earlier is better, but unless you really have things in there that can help people with their anxieties and their uncertainties, then I think, then it's problematic. So let's look at the services. The rare dementia support groups are extraordinary for people. So if you have an early diagnosis and you're lucky enough to understand that you've got rare dementia support there, that you're able to have somebody who can counsel you either online or in person, that you have group activities so that you and your family can talk to other families who've been affected and learn what works and what doesn't work. That's such a massive comfort in talking to families about how that works. And I really think the opportunity for research, which my own sister certainly wasn't offered, but which she would have willingly participated in. And with the rare dementia support groups, you not only hear from researchers about what's the update in your area, but you also get the opportunity to participate if you would like. So there are so many good services that the rare dementia support groups offer, but it is only a small percentage of people who've got the diagnosis are actually using the service now. And one of my roles and the role of the advisory board is to grow that service so that more people have an opportunity to be part of it, to participate in it, and to get the support that they really need. What I've learned from my sister's diagnosis, and it's very hard, as you know, when it's personal, two main things. One is that she was anxious before the diagnosis about what was wrong with her. And obviously we were worried about what the diagnosis would be. And some of us, like me, had an inkling of what that might be. And so the anxiety about what was happening to her with the diagnosis, it was her worst fears, to be honest, had been realized, that this was the diagnosis she feared the most. As we know from AI UK's polling, people fear dementia. She was fearful, and she was the uncertainty of it. What's going to happen to me? Am I going downhill fast? What the progression route looks like. What was a really good thing, and I would say this, and because it's not mentioned very much, is that we had a discussion, should she tell her friends? She talked to her friends, and it has been amazing. They have offered extraordinary support, love, gone out and about with her, made her life really rich, the quality of it. She lives in Scotland, not near me. She wants to remain there, so I'm up and down, but the difference that telling people about the diagnosis has made, and having them support her in ways they can, but she's still her own person, and having her own agency is really important. And that's the main thing that I've taken and what we're trying to make sure that my sister has is the agency to do the things she wants to do. So she can't drive, but there's lots of people willing to take her car and drive her places. She can't read, but there's anymore, not really, but there's lots of audio things she can listen to. There's lots of people who want to go to the theatre with her. So those are the kind of what makes your life worth living. And I would say we should put a little bit more emphasis on that.
Thank you, Shirley. And I think obviously your personal perspectives on this are really powerful and helpful. And, you know, I guess we all wish your sister well. Just to follow up on that about the point around agency, I'm sure it sounds like she's got a really loving support network around her of people who can advocate and support. I guess, presumably, you know, the challenge is not everyone's going to have that support network. And then that creates a bigger challenge for those people who perhaps don't have the same level of supports.
I think that's a great point, Susan, because my sister actually is divorced and her son is at university, so she lives alone. So I have in my notes here, what do we do when people live alone? Where she's very lucky because all her neighbours are popping in and out all the time. And I would say that in where she lives in Eastern Scotland, that the care team, these consultant psychiatrist, has a team around her. And they are in touch with my sister regularly. And I find that very comforting for me. And I think she does too. The difficulties that I'm seeing sometimes because she's on her own is with technology, because it's good to be online and to be able to talk to people and say, for example, to get the RDS services. But if she's on her own and having trouble with technology, then she's not able to access those. So I think we need to think about what are the points that it's easier for people to get the support they need. And sometimes it's not a lot. It's just thinking through what those things are. And, you know, we really do need to have support so that people can stay in their homes as long as possible.
Thanks, Shirley. Can I move over to Nick? Nick, what are your thoughts, obviously building on what already has been said?
Yeah, well, thank you very much. And I'd also like to thank Young Dementia Network for the invitation. And it's something I feel very passionate about, so you'll have to forgive me if I get a bit evangelical about some of it. I'd also like to, you know, Susan, I think having hard data from those surveys is really important. So thanks to AR UK for that. And you know, a big thanks to Zac and Imran, Zac being very, very articulate there and brave. And you too, Shirley, for sharing your personal story. That's you know, that's important. I'd like to start with something that I feel there was so much in Zac's little film there that just hit so many important points. The delay in the diagnosis, in that case, took 3 years. And we often need to put evidence, research-based evidence on some of these anecdotal things. So in young onset dementia, the average delay to diagnose is almost 4.5 years. In later onset, it's under 3. I mean, that's young onset dementia is also much more likely to have an atypical presentation, maybe with language or visual problems. That adds to additional delay. So we're building in an additional burden on people with young onset. But I think that where I'd really like to talk about is there's been this historical nihilism, and Dr. Kushan talked a little bit about that, about people feeling like, well, what's the point of making a diagnosis? There's not, historically people thought, well, it would just upset people. There wasn't anything. Doctors don't want to do it because they historically felt there wasn't much they could do. And they felt, you know, we have to recognize our own feelings of inadequacy. But I think we surely should be in a much better place. There is so much, and Zac ticked some of these boxes here around what can be gained from a diagnosis. All that the stress that the family were involved in. I remember vividly the husband of somebody saying to me that it has been an agony of not knowing. and that how distressing that uncertainty is. And we all, again, historically had felt that, oh, well, if you make a diagnosis, as Shirley was implying, you have this anxiety, will it make things worse? There was a very big study done in Washington University in the States, where they took patient and partner who had a diagnosis of some memory problem, and they assessed in terms of anxiety and depression before and after a diagnosis of Alzheimer's disease. And in both patient and care, anxiety and depression went down, which might be contrary to what you thought. The ability to access support, benefits, legal advice, symptomatic treatment, plan for the future when people can still be most involved. And as in Shirley's case, only if you can involve somebody when they are still able to interact with their friends, can they access that support network. And so I think the benefits of diagnosis are very, very clear, and the downsides are over-exaggerated, and the evidence doesn't back it up, and the delays are just shocking. But of course, one of the things that would transform the purpose of a diagnosis is if we just have better support, post-diagnostic support for people in their homes, keep them in their homes, for families. And that is probably a dreadful indictment of our systems.
Thanks, Nick. I mean, I think I'd like to come back to the theme of support, because I think that's really important. But I just think your point around data, Nick, I wonder what other panelists' views are. We don't collect much data on dementia, so it's hard to kind of evidence the challenge. I can see in the chat someone mentioned that obviously if you're at the site, if you're potentially on a cancer pathway, there's a process and a timeliness, and obviously some of that is obviously understandably about the kind of the impact of a fast developing cancer. But part of that is also there's much better data, there's much better tracking. So I wondered if any of the panelists had views around how data might help improve the situation. Chris, you've got your hand up. Did you want to go first?
I think, again, when it comes to data, that's the most powerful thing. The difficulty with clinicians, including myself, is we are not very good at working with data, because we are good at seeing patients, talking to them. So it is about that, data needs to be like a writing on the wall. You need to have it in front of you, like the donuts, like these things. Like, if my patient asks me in the clinic and says how many days it will take for me to get my scan, I should be able to give them the data. On an average, between January and March, it will be 8 weeks, but for you, it will happen. So, every step of the way, we need to have the data. And also, coming back to accuracy of where I was going to come. Thanks, Nick, for mentioning. I don't think there is no doubt about getting a dementia. I think we shouldn't have. It's a no. We should move away from, do you need to know about dementia? Whatever outcome, everybody wants to know. The difficulty here, there are a lot of kind of pathways that are actually patient unfriendly. Look, every step of the day, way there is a delay. Like somebody mentioned in the chat, if you have a funny cough, you are in a 2-week rule, get a scan, get your swab done, get even a lung biopsy done in under a month. And if you have an intellectual, as they put it, a problem, and you need to 6 to 19 months to get a scan. So it's not just about the scan. And the other thing I find is empowering. My counterpart in America, he mentions about, we talk about being precious about only one professional work group can diagnose dementia. It is about it's a community. Recently I was talking to a community physicians in United Arab Emirates. They're asking me, can you teach our GPs how to diagnose dementia? I'm not saying that I need to be careful politically that I'm not here to GP bash. At the same time, there are, when it comes to chronic disease management, it's a support mechanism Shirley put in. So if you do know where you are going, you can get lots of support. We've got in Stockton, we've got a Living Well Dementia Hub. I can give them the address from the clinic. They can drive, pop in there, get all the information in a nice environment rather than a clinic environment. So we do need to look at clear support, but every step of the way, when there is a delay, the data needs to be telling us, like, if I say 43% of, psychiatry hospitals, communities do not have access to PACS, we need to be saying by 2024, can it become 15%? So that is how the data should be used. And one last point with regard to research, there is a clear issue, where there's a lot of initiation from joint dementia research campaign and various things, but I do feel fundamentally, when you start dementia journey, asking that one question, would you be interested in any form of research dealing with dementia, and then getting that consent. And like even today, it probably missed my memory. The patient, as he was walking, he said, is there any place I could be a guinea pig, doctor? Can I go and do some research? Because when I had the problem with my previous condition, the research really helped me to engage. So can I do that? So, patients are quite keen. It is about us facilitating, supporting that research is really important. Thanks.
Thanks, Krish. There were lots of good points
It's in there. I just wondered whether either Nick or Shirley got any other comments around sort of that role of data and that helps to make the case about some of the challenges.
I personally think data is really important. I think we should look at the progress that's been made in other diseases, and often it's using the data in advocacy with both central and regional healthcare, but also, the wider community. Alzheimer's Research UK and others have done a great job in advocating nationally so that we have the Dementia Challenge and more money coming into the field. But it's clear that we need a default position so that every patient is treated the same when they go into the GP surgery. They can expect the same kind of trajectory and pathway, and it's too easy, and we've seen this between social care and the health service, to push those with dementia aside for the things that are perhaps thought to be easier to deal with and treat. And so there is a Cinderella feeling, and there has been, about Alzheimer's disease and the other dementias. And I think the voluntary sector, the charities and the researchers have done well to get together and really push that. And the data makes a massive difference in that. Just to add to what Krish said about training, the Rare Dementia Support, there are training programs for doctors and nurses and others in this area. But again, that should be a default, that should be part of the training, underpinning all medical training. The numbers are huge, as Susan pointed out earlier, and therefore, if we're going to have equal standing for dementia with other diseases like cancer, then we really need to up the ante and shout quite louder. The voice needs to be very loud, I think, around this.
Thanks, Shirley. Nick, anything you want to
Add around that?
Yeah, well, I agree with everything that's been said. Data is powerful. I think we need to just change the whole expectations and what people feel they can deliver, and data does help in showing that it can make a difference. The reason why there's a 2-week wait is because for cancer is over decades, people have shown that outcomes were changed, and people have always said, when we have disease modifying therapy, there will be a much more timely diagnosis. It will be better. But actually, we have the knowledge now that we make a huge difference to patients and families. All those things that Zac said, relief, come to terms, all the stress. So we clearly need to plan for disease modifying therapies, and the pressure really will be on then, because then the clock will be ticking in people's cognitive decline that will be irreversible. At the moment, there is a sense that a delay doesn't lose people much, and that is wrong, and we need to change that with data.
Thanks, Nick. I'm going to ask one more
Question of the panel and then go to the questions that we've got in the Q&A. Just coming back to this point about support, I mean, that itself is a huge topic, which I appreciate we won't do justice with one question, but I guess if there was one starting point or step point that you think would help as a step in the right direction towards improving that kind of post-diagnostic support, what would be your top priority? Manny?
I think, first of all, time. I think the key post-diagnostic, again, there is variability, giving that adequate time and space for people to come back, because obviously it's like, life-limiting diagnosis we are providing. Like, today, one of the appointments I had was, I gave a diagnosis in a difficult circumstance in a corridor a few weeks ago. And then today I booked 1.5 hours with the family. But it took 1 hour and 45 minutes. But sometimes, I probably covered the same grounds. Some of the things I probably repeated a million times. But when they went out with information that is digestible, accessible. Again, it's, we keep saying the cliche of rocket science. It is about, you mentioned those points. It's a simple question. Can they eat? Can they go wash themselves? Can they, what happens in 3 months' time? What happens in 6 months' time? There are unanswered questions. It is about ability to manage their ideas, concerns, and expectations, and also allowing them to pause and get back. And one final point on that would be to say, it's the same mom before the diagnosis and now. It's the same dad before the diagnosis is now. That living well is still a possibility, is absolute possibility. There are people driving, there are people managing accounts, there are people managing meetings, there are people in full-time job. So giving that connectedness and hope is the key to me.
Thanks. Right, and I think that point
about time is so important. And, I think as you're articulating, there's so much to discuss because so many people have very poor understanding of what's going around with dementia. So there is understandably so many questions about what it means. Shirley, what would be the top for your kind of support, improving post-diagnostic supports?
I would say, honestly, having everybody being entitled to a caseworker so that one person coordinates everything. I think it's very, very difficult for carers who've got the emotional load and they're trying their best and then they've got to sort of coordinate everything. I think a caseworker who's knowledgeable about the disease, who's there for the carers and is primarily there for the person and can make life easier. And that just doesn't exist at the moment. And I really think ought to, particularly when we're in a point where we don't have those mitigating treatments, then the caseworker is absolutely critical, I think.
Yeah, thanks, Shirley. I think
it's hard enough for anyone to navigate the care and health system sometimes, even when you're within it. So for someone outside of it, perhaps with cognitive challenges, is we shouldn't underestimate the scale of that challenge. I think that's really important. Nick, what would be your top wish list?
Well, sadly, it starts with the obvious resource, because all of the things we've described, we absolutely need the funding to be in place to allow it, but also we need an expectation, a right to firstly the information people often so lack. They get given a diagnosis in an inappropriate way, they don't have the follow-up information, and then are very, very poorly joined up services. You either need, as Shirley says, somebody who really takes you on and advocates for you, or you need a far better way to navigate the system. And both of those require the funding to be delivered and to be delivered efficiently.
Thanks, Nick. I mean, I would say
I agree with all of your points, and I guess resource, then it comes back to data again, because we have to justify why we have that investment. So there's lots of challenges ahead. Thank you. I'm going to move to questions because we've got a really interesting range of questions. I'm going to so first of all, a fairly quick one that maybe Shirley could answer. Does the Rare Dementia Support Group cover people with early onset AD? Is that under 65?
Yes, it does, because that's obviously rarer than post 65. And I would really invite people to join the RDS groups. There's some really energetic, there's some wonderful researchers to talk to, there's some great people to meet, they'll be in your area. And so take a look at the website. It started out, and I would say I have a big, great admiration for Nick Fox here, who started the rare dementia support groups at UCL, and all of the young researchers who are involved in it. I mean, they started these groups because they knew they were necessary, and as clinicians they could see there was the need. So thank you, Helen, for putting that up in the support. But I would say, yes, please go and visit and see what RDS has to offer, and the counselling is brilliant.
Thanks, Shirley. Just on that note,
There was also a question from someone saying they're supporting a young person in her early 20s whose dad has got young onset dementia. Is there any kind of peer support blog or social media type of group? Because actually I think she's less interested in a face-to-face group. Do we know of anything that exists like that?
Ooh, now there's a really good thing. I think one of the good things about the rare dementia support groups, if that person gets in touch with the young onset group there, is to suggest that they set up a social media group there, because in fact there may be many people who would like that. And one thing about the rare dementia support groups is we react to what people want, and so then we could set something up that would work. I mean, what I will say too is that the Canadians are now taking on the concept of the rare dementia support groups too, because they've looked at what's happened and how quickly things have grown in the UK, and taken, and piloting it in Canada now. So anything new, I think we're at the beginning of lots of new things, and so we should begin just trialing things. And if somebody wants that, absolutely, we can set that up.
thanks, Shirley. So I think the
Call to action is if people reach out to the local groups and highlight that. And I guess that, that doesn't have to be a regional thing necessarily, depending on how it goes. Just moving on, maybe Nick wants to start with this. One of the questions was, do we know why it takes longer for a diagnosis with young onset dementia to be made? And they've said some data around this would be helpful. I know there's some work Young Dementia Network have done on this, but Nick, what are your thoughts on what are those kind of barriers to people?
There's several. I think for a start, we have our preconception that that's the public at large, but it's clinicians working, that the people with dementia are typically older. So we start with a sort of assumption, a preconception that there must be something else going on. And the number of people who've been told, come through my clinic, oh, my wife was told it was the menopause. We were told it was relationship problems. There'd been a bereavement, her father had died. It must be that. But in addition to that, a younger onset, and this is just biology of the diseases, are more likely to be atypical. You're more likely to have something like PCA with a visual presentation or a language presentation. And you're more likely to have frontotemporal dementia, so a behavioral presentation. So these younger forms are also atypical, and our diagnostic services are not used to that. And so there's often a search and lots of unnecessary investigations, or just being dismissed as this is depression, it's the menopause, or whatever. So it's some of our preconceptions are the problem.
Thanks, Nick. I think that's put it very succinctly. Chris, could I just ask you?
There's been a question here, and I appreciate some of this insight comes from our work, but as a psychiatrist, about perhaps why there might be different views between psychiatrists and the public, and perhaps, the model that psychiatrists develop in terms of their clinical practice, in terms of, why we might see some of those differences from your perspective between clinicians and perhaps the public on diagnosis.
I think, again, sometimes it is about, I know I shouldn't do that, but it's about how the question is asked, isn't it? Like, if a matter of fact, I think it's really important if you put the context. If somebody listening to this webinar today, and then if I had to do a spotlight audit on psychiatrist, what would you like? The percentage might be different. the difficulty, I think Nick alluded to a few things. Probably a decade ago, the things were a bit of the learned helplessness of, again, I have been challenged in a group of medics conference where why are you breaking your head about diagnosis when you don't know what else to do after diagnosis is always the caveat. But when it comes to psychiatrists, I think the key is that accurate diagnosis. And then we do talk about that accurate because of that, we go back to the resources, timely, effective, accurate diagnosis. What people are worried sometimes is, sometimes I have done it in the last, couple of years with services being, slightly, removed, that I may have to review diagnosis, which were a patient who were diagnosed with dementia to have a depression that was missed. So there are things. So they do worry, giving a life-limiting, life-changing diagnosis. So it is about, if you were to ask, if you have the right facility, right resource, and right support, would you have any reservation in giving a diagnosis? I hope there should be a 99 or 100% agreement that everybody would want to give a diagnosis. I think it is about that. They're probably answering for everyone in that bargain, shot themselves in their foot. I think that's one point. And then I was going to come on to, somebody asked about the question about social media. Shirley, I do think that that's really important because stigma is something very important. Like, people, again, people with the younger onset, even though they've gone through the motion and got the diagnosis, it can be devastating, and they may want to have a quiet word with people. So I'm just going to bring a point in Dubai, the autism group have a private WhatsApp kind of a community or a private Twitter community where they use that 247, like-minded people providing that support 247, but without affecting phone calls, without meeting anybody face to face. So again, we are some can be aversive with IG, but sometimes some of these things are really important. Thank you.
Thank you. I think that was
a really good pushback. And, I completely accept some of these, you ask people questions, you will get a slice of an answer. And so I think it's more about some of the spirit behind it. There've been a few questions about some of the insight that I shared, so I'll try and answer those quickly. In terms of how far ahead of symptoms we're suggesting people were asked, we weren't specific about that. It was more a kind of point of principle. I know that's not hugely specific, but that was the reality. In terms of, and I know Manny mentioned this already, in terms of who might give a diagnosis, we didn't dwell into that. And I think I agree with Manny that if people have got the right skills and competencies, the right training behind them, and are in a position to kind of advocate and empower, that should be open to whoever's most appropriate. I know there's a question about diverse communities and some of these perceptions. Could I direct people to the Alzheimer's Research UK Dementia Attitudes Monitor? We've done 2 waves, and the first wave particularly that was done in 2019 did have a boost for a range of different ethnic groups, and so has a bit more data, because we all know that ethnic diverse, ethnicity and NHS data is poor at the start. So there is more information there. I do just want to go to, because I'm conscious I've got 1 minute left. Nick, in a minute, very quickly, there's been a question about the potential of blood tests and the roles that they could have in supporting more accurate and early diagnosis. Where do we think we've got to? Do we think they're going to be soon? What would you say in about 30 seconds, please?
I think they're going to transform diagnostic processes. They're going to be a fantastic first screening, and they will make diagnosis more equitable and more widely accessible. They'll be a good thing.
We look forward to that day and what it can add. Right, I'm going to stop there. We will answer any of the questions that are outstanding. Over to you, Tessa.
Thank you so much. Thank you so much, Nick, Susan and Shirley, and I know Manny's had to leave. You've done a brilliant job for us, and there's so many challenges to this, to diagnosis and accuracy, and the support offered during and after and such like. But there is encouragement and hope here, because there's people like yourselves really, putting your energy, expertise, and time into improving things. So many thanks for sharing what you know today, and thank you to all attendees. I just want to remind everybody that there'll be a follow-up email which will include the slides, the recording link, the unanswered questions, if we can get those answered in time, and any useful bits and pieces that come in the chat, of course. And I think we will be able to share the chat with you as well. So that's all going to be useful. There will be a very really brief survey, which is 3 questions. And one of the questions is there anything you'd like to take forward for the next webinars in May and June? And anything from this session or anything to do with young onset and improving the experience of diagnosis? We would love to have your thoughts, all attendees and panelists. We would love your thoughts. Our next webinar is 15th of March, 12:30, 1:30, improving the diagnosis process for people with atypical symptoms. And as Shirley's mentioned, the Rare Dementia Support are presenting that one. So it's a lovely follow-on really from this one. Just want to say thank you so much. You've been excellent today. Thank you. End of webinar.
Thank you.
Thanks.